This episode of Transmission Interrupted was recorded May 8th, 2025. This is Transmission Interrupted, a podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello, and welcome to Transmission Interrupted. My name is Jill Morgan. I'm a nurse here at Emory University Hospital in Atlanta, Georgia. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S., with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. On today's episode, I'm very happy to have one of the founding and I think sort of visionary members of NETEC with us, Angie Vasa. Angie's got a background in trauma and transplant critical care nursing. She's the Director of Consulting Services and Metrics Development for NETEC. We'll talk more about that in just a minute. She's also the Director of Biopreparedness and Special Pathogens Programs at Nebraska Medicine. She serves as the Program Director for the Region 7 Regional Emerging Special Pathogens Treatment Center, their RESPECT, or Treatment Center, and is a scholar at the Global Center for Health Security at the University of Nebraska Medical Center. So, Angie, it made me tired just to listen to all that you are responsible for, but I'm so glad you could carve out some time for this because we are actually going to run through today one of the assets that you guys have developed to make preparedness a little easier for people.
Yes, thanks for having me, Jill. I'm excited to talk about this resource in particular because it really is meant to be accessible to all healthcare facilities, frontline healthcare workers, and I think it's one of our forward-facing tools that everybody can get good use out of.
Yeah, I really think that this is a very helpful one. I'm going to poke it a little bit because I come from an ED and critical care background, but in smaller facilities. And so I think I've got a lot of questions for later. So I'm really excited about this. I want to just start by level setting some language here because we use the term VHF a lot. It's just become part of our lingo. But can you take just a minute and talk about what special pathogens are, about defining sort of VHF? And then if there are some other terms, I think we're not going to talk about one of your favorite terms today, thus BORSA, and sort of like these ideas of documents and tools to help us get prepared all have these acronyms and refer to things in acronyms. So let's just start with getting some of that out of the way.
Yeah, I love that. Let's level set from the beginning. So when we say special pathogens, we really are referring to a pathogen which can cause an infection, which is easily transmitted from person to person. It has high rates of morbidity and mortality. There are limited or no medical countermeasures. The risk to the community and to the healthcare system infrastructure is high if there is escape of infection. And so these are really pathogens which should be cared for in a specialized unit with a team that's trained to provide care for the duration of illness. So viral hemorrhagic fevers, or VHF, is a group of these infectious diseases caused by several families of virus. And so when we say viral hemorrhagic fever, typically people will imagine and picture hemorrhagic, bleeding, a lot of, critically ill individuals. But in reality, a large number of patients present with generalized symptoms, just fatigue, headache, GI distress, abdominal pain, and then can progress to hemorrhage. But really is this constellation of symptoms, which can be it's very similar to other viruses. And so when we talk about the viral hemorrhagic fevers and the importance of identifying them early, we're addressing things like Ebola virus disease, Lassa fever, Marburg, or Crimean Congo hemorrhagic fever are the ones that we really intended to address with the development of this particular tool. The SPORSA, which is a term near and dear to my heart, as you said, is our more comprehensive tool. So this is the Special Pathogens Operational Readiness Self-Assessment. And it's a pretty intensive tool with 13 domains or categories of readiness, comprising 54 sub-capabilities and about 450 questions. And it's intended to be a comprehensive programmatic evaluation for facilities that have stood up and said, we know that we would likely identify and keep a patient with this type of a pathogen. And we want to look at all of the domains of readiness, which will help our healthcare workforce prepare to keep these individuals safely cared for.
Yeah. So the VHF checklist we're really here to talk about today. is a scaled down version of that bigger sporsa, right? So it's a little bit more digestible, a little bit more approachable, and maybe for facilities that aren't ready to step up to being somebody that would deliver the entire spectrum of care, but need to be ready. I mean, as we know from the new Joint Commission requirements, if you're a Joint Commission accredited facility, you need to be ready to at least do some of these things from the get-go, no matter who you are or where you are.
Yes. And I think the VHF preparedness checklist is really aligned to reflect, at a minimum, the Joint Commission infection control standards related to special pathogens. It is more inclusive and it captures the elements that NETEC has identified to be basic preparedness elements to identify these individuals, to safely isolate them. And it is meant to be approachable. It is meant to be used by any healthcare worker working in an emergency department or other point of entry. And the way that we had built it was really around some of the critical elements within the SPORSA, but also reflective back of the identify, isolate, and inform paradigm, which we've been teaching for, quite a while.
Right. And certainly I'm a believer in that, right? I think absolutely there's so many subtle things that ED nurses and ED staff members, frontline folks are so good at sort of ferreting out, right? Like people come in with chest pain all the time and very quickly, people kind of winnow that down to, is this somebody I need to get back immediately because this is an MI? Are they having a STEMI? Or is this somebody with a pneumothorax? Or, you're doing a whole lot of assessment in a few rapid fire questions. And I think we just need to adopt sort of the same principle for how we approach somebody who may come in with, like, as you said, sort of vague symptoms, but I need to start asking those other questions. Like, could this be something infectious and worrisome, and I need to think about like protecting myself and protecting my facility and that going down that whole path. So yeah, and I want to go back for just a second because you and I, of course, were both involved in the Ebola patient care from a decade ago now. And, I think that the viral hemorrhagic fever phrase is a really easy one to use, but it's also a little bit of a misnomer here in the United States because for us, they look like septic patients. And if you get to them early enough, we think we can get them over a lot of that critical illness without them looking like what people fear, which is the bleeding from everywhere kind of thing. We just never saw that here because I think we were able to intervene more quickly. So that is the goal, right? Is to get to the viral fever part before it gets to the hemorrhagic part. So yeah.
And I think, when we published this tool, we really intentionally named it the VHF Preparedness Checklist, but it really is intended to help hospitals prepare for all types of special pathogens. So the requirements and regulations around management of individuals suspected or confirmed to have a VHF, including the way that waste has to be, identified, segregated, and processed, some of the personal protective equipment requirements, those are some of the most stringent. And so if we can put these processes into place, they can be customized to approach any other special pathogen or infectious disease that you are worried about escaping into your emergency department. So whether that is a viral hemorrhagic fever, novel respiratory pathogen, measles, which we're seeing reemerge, which we don't categorize as a special pathogen in the sense of high-level isolation, but these same tools will help prepare emergency departments, community hospitals to identify these individuals early.
Yeah, absolutely. All right. So you mentioned like a little bit about who should fill this out, but talk to me about, all right, so we are going to give the URL for this in just a minute. So I understand that people will be able to follow along if they would like, but this checklist, you mentioned like emergency department nurses or somebody like maybe in an emergency preparedness. So is this something that anybody at a facility can request? Is it, I guess when I went to look at it and realized I had to put in my name and my facility, it was a little intimidating for me because I thought, I'm not sure Emory would want me to be the one filling it out, right? Because like I'm not the one in charge of anything. But tell me about that. Like, is that okay?
It is okay. And there's actually two ways that you can access the VHF preparedness checklist. So the preferential method would be the one that you had identified and explored, which is to fill out the live link and to complete the electronic survey. We do have facilities who have submitted multiple of these checklists. And then what that helps us do is reach back out to them and clarify, we've had multiple of these checklists. Here are the answers that were either the same or dissimilar. And then we work with the regional emerging special pathogen treatment center or the RESPECT in that region, and we get them connected back with that hospital. So if there are persistent answers, which say that there's not a process in place, which should be, or there are discrepant answers, we can help them identify where that miscommunication occurred and get them in touch with the RESPECT who can help them address the gaps. The other piece is that we have the ability to request specific technical assistance at the end of the checklist. And so if a facility gets to the end, I'd like to learn more about treatment and care options, waste management options, you can identify that and we will reach out to the regional treatment center to contact that hospital. So building the regional relationship. So that would be our preferred way because we can track the data, we can get back in touch with you. There is an option to download a hard copy of PDF, which is a fillable PDF, which you can either do on your desktop or you can print it out in paper copy. And that really probably feels a little bit more approachable because nobody is seeing your answers. You can, round through your organization, talk to multiple people. And so if you're somebody who's new in a role like an infection preventionist, you're in quality, you're not sure if you're the person that should be submitting something, this is a good way to get started and then collate those answers. And then we would still encourage you to submit that back to NETEC so we can get a better sense of the national picture of preparedness for these types of pathogens.
Yeah, no, I think it could be really helpful to basically get assistance, right? To say, hey, these are the things that, I wonder who else in our area is struggling to find, like X piece of PPE or figuring out what our transport plan would be, some really complex, probably over my head answers. But I also think like it could be helpful if I am that ER nurse who's Johnny on the spot, who really is trying to move our facility forward, maybe hasn't gotten buy-in yet, and be like, hey, I got this thing. And this thing says, maybe we've got some work to do. So yeah, I really like that idea. So I appreciate that. I appreciate you letting people know that there is an alternate way for those of us who are a little cowardly about, actually getting out there. So what all is it going to help guide us about? Like you mentioned 13 domains and you mentioned some PPE and IPC things, but can you walk us through some of the topics that it's going to ask us about?
Absolutely. And so for the VHF preparedness checklist, I would reassure people that it is not the full 13 domains. We have condensed them down. And it serves in two ways, right? One is an advanced preparatory tool to start to think about maybe we don't even know what to ask, right? Where should we start looking to see if we're prepared as an organization? And then secondarily, it can be a just-in-time tool. So somebody is presenting to the emergency department. You've identified something seems like it's not quite the same as it normally is. You've put them in their proper isolation room. This could be an immediate checklist to say, do we have the right personnel? Do we have the right equipment? The areas that it goes through is first and foremost identify. Do you have a process, a plan, and a procedure to identify individuals who may have viral hemorrhagic fever?
And you're talking about asking questions at triage.
Mm-hmm.
Do you have a fever, rash, whatever, travel history?
Fever, cough, rash, and a travel history, which is to an area with a concerning outbreak or epidemic that is occurring. We also have some other questions around, do patients have an opportunity to screen themselves in a portal before arriving? Are there signs that direct individuals to self-mask if they have cough or fever? So some really basic entry questions around, is there opportunity to identify individuals? So that's step one. And then we move into isolate and we ask some specific questions around the isolation spaces. And so thinking about, do the staff know which room we would put an infectious or potentially infectious patient in? Is that a private room with a door that closes with access to a bathroom or a commode? Do you have a negative pressure room in your emergency department? And could that be prioritized for these suspect cases? Is there a way to document which personnel are providing care for this individual? Should they, rule in so that we know who to communicate with and how to track that monitoring? And then are there written plans for internal transfer? So if we're an organization that's going to keep an individual in an inpatient area in a dedicated isolation space, is there a written plan that talks about how to move them either through the emergency department or to another area within the organization? And then to the paradigm of the III, the identify, isolate, and inform, do we have a communication checklist or some sort of a document that says internally, who needs to know that we've identified and isolated this person? And then externally with public health laboratory, other partners that you regularly work with, how do we contact them and when do we contact them? So those are the first 3 steps. In addition to that, we separated out personal protective equipment. There's always a lot of questions around, do I have the right equipment? How do I find the right equipment? Have we gotten training on the right equipment? And then it gets into a little bit more detail around, is there a dedicated space to put on your PPE or to don in a clean area? Is there a dedicated space to doff that PPE so that you're moving from the dirtiest area of care to a clean area where you have the opportunity to remove those contaminated pieces of equipment? And then we also reference back to the DASH tool, which is a tool for facilities to help determine what level or inventory of PPE do they need based on multiple scenarios. And then the last 2 pieces that we look at are really treatment and care, and then transportation, and then waste management. So it does go into 6 different areas, but they kind of go in sequential order. So we've identified them, we've gotten them into a safe room, we've notified our partners, we've identified what we need to wear to safely assess and provide care. And so then there's a little bit more around what level of care are you prepared to provide, and what should you be thinking about when we collect lab specimens? Where do those laboratory specimens go? What level of care would you provide while they're in your facility and awaiting laboratory testing? And then what other resources would we have available should that condition deteriorate and we need to manage decedent remains? Waste management and cleaning and disinfection, and this really aligns with the new requirements from Joint Commission around the ability to safely secure and sequester waste until we identify whether or not it needs to be processed as a Category A hazardous substance, which has a lot more stringent requirements than our regulated medical waste. It talks about identifying a proper vendor or inactivation procedures for keeping that waste on site and moving it from Category A to Category B. Guidance on PPE and who should be handling that waste. And then with the cleaning and disinfection, emergency departments are busy, right? We need to know that they're once the patient is either ruled in or ruled out, that we can turn that room back into service. And how do we safely do that to mitigate any additional spread of infection, whether it's a special pathogen or any other infectious agent?
Yeah, because really that sounds like a lot, right? And it is a lot. And yet that last piece is so important to hospital operations. We have to take care of whatever shows up at our doors. I mean, it always frustrated me as a young ER nurse. We'd be like, we're on bypass because we're just full. Mm-hmm. It doesn't matter. That might stop some ambulances from transporting something to you, but it's not going to stop the guy that just cut his arm off, right? It's not going to stop somebody from riding up, delivering a baby in the front seat. So that stuff is always going to happen. And the question is, how do we respond cohesively, safely, and then reset our facilities so we can keep doing what we do best, right? Getting back with this operation. So I think I think those kinds of things to me are good selling points, right? For some of the people who might be a little resistant to, we actually have to get ready for this. And I want to also go back to, do you have a negative pressure space? Do you have an airborne isolation room? Those are questions I think people should be asking themselves because, as you said, measles is on the upswing. Mm-hmm. But so is H5N1. While we haven't seen a lot of person-to-person spread, it's still something out there that everybody's watching. And then we have some places in the country where tuberculosis is again on the rise. Mm-hmm. Those are pathogens that healthcare workers need respiratory protection for. So no surprise to the people who have listened to me before that I'm going to go on a short rant about the importance of PPE, but there it is, right? Now, I also was so jazzed that you mentioned waste because we just recorded this great session with some of our waste vendors from across the country. And hearing them talk about like how important this is and what a big deal it can be was super helpful. And it really will help people clarify like how to do this in a reasonable manner. So I think that actually it sounds like a lot, but then when you break it up, as you mentioned, it really is sort of these pieces that make a lot of sense for what we need to do for patients.
Yes. And I would say, while it sounds like a lot as we discuss it, it really is meant to be completed in 15 to 30 minutes. So depending upon how familiar you are with these processes, some people it takes a lot longer because they have to search out the answers. But even if we don't provide all of the guidance or the solutions, you're asking the right questions to understand what our next steps are. And so this really is meant to be a rapid tool to quickly evaluate the processes, start to put a plan in place. As you know, this is one of the tools that we have used in real-time response. So as we're tracking outbreaks and we're looking at cities where patients are potentially going to arrive based on air transport or your typical airline patterns, this is a tool that we have used to provide both self-assessment and peer review. And so, while it does sound like a lot, it is approachable.
Yeah. All right. So I wondered if you wanted to walk us through maybe like a sample case, like walking through, maybe not at the University of Nebraska Medical Center, but you're out in Bellevue, or pick a smaller Nebraska city.
Yeah, absolutely. So I grew up in a small rural community. We had one community hospital, and that's where everybody went, whether it was, a broken arm, an MI, that's your only place to go. And so when we think about an individual that's from the community, they're going to go where they feel safest and where they know that they can get care quickest. And so they're not going to know to go to a level 1, level 2, or level 3 special pathogen system hospital. They're going to their community organization, which is where we all work. And so when that individual walks through the front door, really thinking about who are they encountering upon arrival, right? Are we encountering security? Are we going right to a triage desk? Is it a waiting room with a large number of individuals in it, or is it a separate spot? So that very first interaction, regardless of whether it's security or front desk, triage, the nurse, that's really the point where we want to make sure that we are asking the right questions and getting the information from that individual, identifying their chief complaint and that the symptoms that they have are consistent with something that would be concerning, like fever, cough, or rash, and then asking those follow-up questions, which can be in the electronic medical record, but can also be a hard copy form that's just an algorithm that the front desk staff follow because it hasn't been built out electronically. And so really understanding what are the questions we want to ask around travel, or what are the hotspot countries and areas that we're monitoring because there are emerging outbreaks.
I like that. I think that a lot of people were like, oh, well, I haven't heard about Ebola, therefore I don't have to worry about asking these questions. But I think it's really important for people to understand, first of all, there are a lot of these pathogens that are endemic in parts of the world, or that you just don't hear about because there are enough cases that it's not one of these things where there's a huge sudden spike in number of cases and therefore it makes the news. So things like Crimean Congo hemorrhagic fever, or CCHF, things like Lassa fever, in some places are not uncommon. And so I think that have you traveled is a great question about what could you have been exposed to? And that can open up some other questions, right? Because maybe they didn't go someplace where they might have gotten that, but maybe they went someplace and they have malaria. Maybe they went someplace and have cholera, or, pick another pathogen you don't want. There are a lot out there. So I think that, to me, that really is just saying, look, there's another set of questions we want you to have primed in your head and have this index of suspicion that if you see somebody with something that might be contagious, ask the next questions, like just go there. And I think it's great that we're sort of trying to bake that in, if you will, to triages everywhere, because anybody can travel, right? Like rural Nebraska has people that go on mission trips. Rural Nebraska has people that go on research studies or have family members in different countries. And so it's not as if you're just going to be able to identify them without asking.
Right. And I think, I'll refer back to our colleagues that just had a case that presented to a hospital here in Iowa, which I think raised a lot of index of suspicion, to use your term, around like people move to the U.S. from all over the world. And so they go back home to visit, come back. And so it might not even be that you went on a trip. You just went home to visit family. And so having an individual who can present to the community hospital, and even with those first questions of, did you travel? Where have you been? The initial epidemiologic investigation might identify we should test for malaria. We should look for these other pathogens. And it may not be that you would think of these differential diagnoses at the very first pass, but that's where that informed piece comes, right? So you're like, something is still not fitting into an easy diagnosis. So we reach out to hospital epidemiology. We reach out to infectious disease. We reach out to a more experienced triage nurse who might have this on their radar. And so that's where that next step of, we've identified that there's something that we should follow up on. And then it's contacting the right individuals to ask those additional questions. To your point, is it an endemic disease that's in the high season? It might not be an outbreak that we're tracking, but it's something that we should be looking for.
Yeah. And that kind of thinking early, one of my other favorite topics, is healthcare worker safety, right? Because if I've identified that early, guess what? Early intervention lets me put a mask on the patient and put a mask on myself. Probably do some hand hygiene, maybe back up or think about putting this patient in isolation. Now, that doesn't mean I'm going to lock them in a closet and forget about them or put them in someplace and put a big sign on the door. We're talking about this. We just need to exercise some caution and then ask the next set of questions. So, like triage isn't designed to get your entire medical history. It's designed to help us figure out how sick you are. And in this case, this is one of those things where you don't want to miss it early. We had a case here, not of a special pathogen, but of something you don't want in your oncology waiting room, which was disseminated zoster. And that's just a nightmare for that patient, for the patients that were in there or family members that were in there waiting, and for all the people who had to do follow-ups and monitoring and tracing of those people. We want to avoid that. So that early intervention to me is so key for protecting our healthcare workers and our healthcare environment. That's great. That's great. All right. So now we've got this person. We've identified them. Hopefully we have some PPE we could put on that's available, that's appropriate for this suspicion, right? Transmission-based precautions are always a little tricky when you're not sure what the pathogen is yet, but you can have some ideas about things and you can say, well, I want to just exercise caution. So I've got some PPE. I maybe am calling maybe it's my infection preventionist. Maybe it's my house epi. Maybe it's, first person I'm calling is actually my ER doc to say, hey, I would really like for you to see this one next. I'm not sure what's going on here, kind of thing. So getting into all that, of course, is taking us away from the actual tool. But I want to talk about what happens next in the tool. So I'm using it. I'm seeing these gaps. You mentioned whether we get help because we ask at the end for help from NETEC, or what should facilities end up with when they finish this document?
Yeah. So at the end of completing this document, it is set up as a binary checklist where every answer is expected to be yes. So it's really easy to understand where are we at and where are the gaps. And so at the end of this checklist, you should have a prioritized list of items that could be looked at if any of them are no, or if an entire section is no. It really is a starting point to help the person who's filling it out and that organization start to put some of these procedures in place. So, is there a written plan for the management of waste generated during the care of a person suspected to have a special pathogen? Well, maybe we know that we would have to do something different with the waste, but it's not written down. So it gives an indication of here's the next step, is starting to look at the written plan. I think at the end also is where we would be able to identify who can you talk to, right? Is there another hospital that has these plans in place that we can connect you with? Is it your regional treatment center? Is there another public health department that we're working with that we know would give you guidance? So the intent at the end of filling this out is to just understand for these 6 areas, what proportion of answers were yes? And for the ones that are no, we can get you in touch with people who have the answers if that expertise isn't already internally available.
Yeah, because I think none of us want to recreate the wheel, right? I read the APIC message boards all the time. People are like, could somebody please share their protocol on X, Y, and Z? That's exactly what we should be doing, right? We want to share resources so that nobody has to sit down and try to make up a plan for viral hemorrhagic fevers from scratch. That's just 100%. Why do it, right? Yeah, absolutely. And then it's also important, I think, to understand that even if you at your little hospital aren't aware of it, there might already be a regional plan or a state plan or a plan for transport or a plan for where labs go that you just don't know about. And so getting connected can help you understand, some answers to things. So I like that a lot. We've been talking a lot about this, so I want to go ahead and give this URL. And of course, we'll have it in the notes for the show and probably in the NETEC blog that will go with us. So the URL for this VHF checklist is netec.org/VHF checklist. And I verified that it worked.
Fantastic. Yes, we try to make it as easy to access as possible since it is an actionable tool.
Yes, absolutely. Absolutely. So grateful for that, because I know sometimes navigating websites and things like that and trying to remember what it was is difficult. So if you can get that in there, you're doing really well. And I'm glad you mentioned the DASH tool, because we do have links to the DASH tool as well. The DASH tool is actually designed to help facilities decide how much PPE and of what they might need to take care of a patient, whether it's for 12 hours or 24 hours or longer. So it's very helpful to not only think about what you need, but how much of it do I have to buy? Because things have expiration dates, and you don't need to just stockpile stuff that you're not going to use. Excellent.
Great.
All right. So Angie, I think this is a great tool. And I'm glad that you sort of made me feel better about it, that I feel like it's not quite as intimidating as it was before. What would be your, I want to leave people with these messages? Because I think that, I want to just give you the opportunity to just lay it out there.
Well, I think the first thing I would say is that ready or not, patients are coming. To quote a dear colleague of ours, that's the truth. Patients come whether we are ready or not. And so we want to make sure that we get you as ready as possible, as early as possible. So if you are an infection preventionist, an emergency department nurse, a quality lead, visit our site using the URL that Jill identified. Complete this checklist. Once you complete this checklist, we can get you connected back into the National Special Pathogen System. And you might just find that this is the first step in your journey towards becoming a high-functioning special pathogen hospital. So the completion of the VHF Preparedness Checklist can be step one. We'll get you integrated in with your regional treatment center. And then if you want a more comprehensive programmatic assessment, my team is happy to partner with you to take on the spore set and do a more thorough analysis. But I think that's it. It's just, we know that things will happen. We know that infections will continue to occur, and we know that patients will present. So that's what I would leave us with.
Yeah, I think that's great. This was put together really thinking about and having in your head the Joint Commission requirements now for hospitals. If you're Joint Commission accredited, you need to be getting ready. And we know they didn't. It seems like last year, even though the requirements went into place, of course, July 1st, that surveyors were not really poking this a lot. But we anticipate that will not be the case for this next year and after. So getting ready for that is really important. We've done several webinars about the new Joint Commission requirements. So please, if you are not familiar with that, they're available at netec.org. And there are actually some new lab requirements coming into place this July. So there's a lot going on in this sphere. So I think it's a great time for people to do sort of a facility gut check of where things are. So I think that's great. Well, thank you, Angie. This has been great.
Yes, I really appreciate you having me on, Jill. And I think just to be able to highlight that there are things that are available, we are here to help. There's a lot of resources that we can get you into contact with. And I'm always happy to talk about assessment, consultation, resources, and tools. So
just like I am always happy to talk about trash and PPE.
Yes, exactly.
All right. So again, I'm going to give the URL for the VHF checklist is netec.org/VHF checklist. That will get you to the checklist that Angie's been talking all about today. And I really do think that this will at least give you an idea of what you need to work on. And if you want to do the online version, it will even get you connected with some help. So that's great tools to have at people's disposal. So thank you. All right. Well, thank you so much for joining us. For those of you who are, this might be your first time listening, we appreciate you tuning into this episode about the VHF checklist. We hope you'll join us for future episodes on a wide range of topics, from healthcare worker safety, personal protective equipment, again, my favorite, infectious diseases of all kinds, preparedness, transport, all kinds of topics in that area. If you have any questions for NETEC or ideas for future shows, please feel free to contact us at info@netec.org. You can find us on the web at netec.org/podcast, where you can subscribe to future episodes and find more information about today's topic, including some links to the VHF checklist and the DASH tool. So thank you guys so much for joining us. Thank you, Angie, for being here with me, and we'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, a NETEC podcast, produced and edited by Benjamin Madsen, with additional support provided by Britton Clark, Veronica Lavaro, Jason Noble, and Lisa Stone. Special thanks to our guests and the subject matter experts at NETEC for their insight and guidance. This podcast is supported by the Administration for Strategic Preparedness and Response. For more information, tools, and training on special pathogen preparedness, visit netec.org. And don't forget to subscribe, rate, and share the show on Apple Podcasts, Spotify, or wherever you get your podcasts. Thank you for tuning in to Transmission Interrupted.